You get to do double duty today.
All right, good evening, everyone. I'm Dr. Frank Filippetto, Dean, Texas College of Osteopathic Medicine, and welcome to our panel discussion this evening. Our panel discussions on osteopathic medical education, creating change in healthcare. I want to thank everyone for attending tonight, including those who are watching virtually. Thank you for attending. And I also want to thank our provost and the provost office for sponsoring tonight's event and for all the people that had a hand on putting on tonight's event. Thank you. The panelists next to me are experts in an array of fields in the healthcare industry, both locally and nationally. Our purpose tonight is to hear from our experts in regard to what some of the marketable skills our future workforce needs to develop that can change the way healthcare is being delivered. According to the World Health Organization, a 2022 comparison of national health systems found that the United States had the second lowest life expectancy among 17 wealthy countries. The U.S. spent nearly $4.3 trillion on healthcare in 2021, and a recent study published by the National Institutes of Health found that nearly half, approximately 45% of all Americans suffer from at least one chronic disease, and that number is growing. Our country produces almost 30,000 new physicians year after year, having been trained to apply the most updated scientific and clinical information at hand. And yet we continue to have these outcomes. What are we missing? The men and women in the healthcare honorably and courageously go up and above each day to deliver healthcare the best way they can. But our system often doesn't make it easy for them to deliver care in a holistic, equitable, patient-centered way. This has led to an increasing number of physicians leaving our profession as a result of moral injury. This has to change, and it's my belief that our future healthcare providers need to be aware of this needed change and develop the professional identity to do so. I'm hoping our panelists here tonight can give us their insight on how to tackle this problem. It's my honor now to introduce our speakers and our panelists for this evening's discussion. He is the president of the Texas American College of Osteopathic Family Physicians, chair of the Texas Medical Foundation Health Quality Institute Board of Trustees, and our assistant dean of osteopathic clinical education here at TCOM. He is board certified in family medicine, neuromuscular skeletal medicine, and osteopathic medicine. Please welcome Dr. David Mason. We have with us the Chief Medical Officer of Medical City Fort Worth, part of the HCA system, which is one of the largest healthcare systems in our country, the largest producer of GME. He is a board-certified pediatrician with more than 30 years of experience, including 25 years in the United States Air Force. Please welcome Dr. Brett Burton. Also with us is the U.S. Assistant Surgeon General, who holds the rank of Rear Admiral in the U.S. Public Health Service. She is a board-certified physician in both family and correctional medicine and serves as the Regional Medical Director for the Federal Bureau of Prisons, South Central Region. She is also a TCOM graduate. Please welcome Dr. Takora Ballum. We have with us the Clinical Director for the whole health section at the VA North Texas Healthcare System. He joined the VA in 2005 and is a current fellow at the Andrew Weil Center for Integrative Medicine. He is also a TCOM graduate. Please welcome Dr. Zung Lee. Also here tonight is the president of the Certification Board for Professionals in Patient Safety and the vice president for the Institute of Healthcare Improvement. She is a graduate of the AHA NPSF Patient Safety Leadership Fellowship Program and a member of the Joint Commission National Patient Safety Committee. Please welcome Patricia McGaffigan. We are honored to have with us the Executive Director of the Texas Health Institute. He leads a range of research, development, and evaluation projects at the THI aimed at achieving health improvement through research, translation, policy, and partnerships. An avid systems thinker and a public health entrepreneur, Ankit is a trained public health professional with formal training in health policy and management. He provides leadership and training on all THI initiatives and develops collaborative efforts with local, state, and national partners. Please welcome Ankit Sanghavi. So tonight's format, I've prepared a series of questions that I will direct at each of our panelists. I would encourage that all of our panelists continue our discussion, so feel free to raise your hand and add anything you would like to, again, your fellow panelist discussion. So let's get started. Dr. Mason. Dr. Mason, you're currently the Texas ACFP president and represent 1,000 or more of DO family physicians in our state. According to the AOA, in 2010, there were 74,000 osteopathic physicians. Today, that number is 149,000. The number of DOs has doubled in 13 years. Can you talk to us about the growth in the profession and how you think the osteopathic tenets and our distinctiveness as a profession should be positioned to prepare graduates to solve this healthcare crisis in our country?
Thank you, Dean Filippetto. First off, we're not going to accomplish what we're after by just numbers. Just turning out more physicians into practice in the current system that we have is not going to solve our problems. For the past 40 years, at least, we've been at a shortage of doctors in both Texas and in the United States. This system's not currently working mostly because of access to care and because of healthcare reimbursement. Those things need to change. There's a fallacy that access to care is just simply having insurance. That's not the case. Access to care is really geographic, it's socioeconomic, and it also is culturally dependent. And so we need to educate our students about those things and then prepare them to go into areas of practice that will support the patients that need our help. Most reimbursement models are based on what we do to patients, and that is slowly changing, but not rapidly enough. We really need to be rewarded for taking care of patients before they get sick. One very strong part of osteopathic medicine is prevention and wellness, and because of the way that people get reimbursed, it's hard to practice in that model. So we need to make efforts to change those models and have those physicians who do a good job at keeping people well and focusing on prevention, both primary prevention and secondary prevention, benefit from that because that's what's going to help our citizens. Chronic disease management is very expensive, and so continuing along this road is only going to cost us more and more. If you look at what the gross national product towards healthcare is, it's mostly related to chronic disease management. So we really need to impact healthcare delivery by preventing diseases, not simply identifying medical issues. Oftentimes, by the time patients come see us and we're diagnosing problems, it's too late. What we need to focus on is access to good food, exercise, and education. And we need to make sure that our students who are graduating from our colleges and our residencies are prepared to lead teams of educators to help our patients be mindful about their choices in life and give them access to preventive opportunities and stay well before they get ill. I think that really focuses again on osteopathic principles. We look at the whole patient, both mind, body, and spirit, and we try to support all aspects of the patients. We focus on the patient that's in front of us, and each individual patient has their own story. We listen to that story, and we help provide a treatment plan for them.
Dave, how would you define what the role of a physician should be in the year 2023? As we compare, again, what medical schools typically see that role is and how we prepare as a profession, as a nation, that graduate of a medical school, no matter what medical school is, right? Many medical schools have a defined way of training, what they train. Even our national licensure exams are focused on a very limited set of competencies. We have medical students often come to us with a predetermined notion of what a physician does. Is that outdated? Do we have a better definition of what a physician should be in the year 2023, or what it should be?
I think it's our opportunity to redefine what a physician should be. I think if we knew what that was and we were doing a good job at producing that, we wouldn't be asking some of these questions. And so I'm looking forward to hearing from some of my colleagues who are here today who are not physicians to help us decide where physicians belong in healthcare.
Any comments from our panelists to that question? How would you define what a physician today should be outside of the traditional doctor that most of our society sees as what a doctor does every day? What would you say some of those differences are, if there's any differences?
I think it's more of a question of not redefining, but reflecting and re-envisioning the way we have thought about the role of the doctor. And again, speak or share some of my perspectives in my role as the co-lead of the Texas Primary Care Consortium. And when you think about some of the remarks that Dr. Mason made, whether it's the care delivery or the payment transformation efforts that kind of pays for the value that the patient and the system gets out of it, and addressing those social determinants of health or non-medical drivers of health, food, housing, transportation, access. We're really talking about, when I say re-envision, is we have talked about care team, team-based approach, and when you think truly about what it will take to address those non-clinical factors, getting outside those walls of the clinics, you are talking about the physician kind of playing a foundation role in a much larger team that speaks to and addresses those challenges or needs at a patient level, at a community level, whether it's around housing, it's food systems, and transportation, and a host of other social, environmental factors. So instead of, I think it's more about like the ability or the opportunity for us to take a step back and kind of envision this broader system, ecosystem that continues to evolve, and where we have the most optimal value to provide. And that's when we get into a conversation of access to care, even opportunities I've had to speak to the legislature. It's like when we think about solving access to care, stronger safety net, given Texas has a high disease burden or need burden when it comes to uninsured population, I think primary care-centric, physician-led, team-based model, especially when we think about opportunities and addressing need in that clinical domain, we have the ability to get more out of it. And it's that recognition both from a physician perspective, but the larger ecosystem, and rethinking the way we have thought about it. And some of that is happening. I think I have to agree with the remarks. But what the questions remain are the ability to replicate, the ability to scale. What we are not seeing, but that's where the opportunities, I think, that we can be thinking about today, and conversations such as this are the right space.
Thank you. Any other comments from our panelists?
I think what I would amplify on both of your comments would be the importance of physicians as improvers who really understand and know the science of improvement. And I know, coming from the Institute for Healthcare Improvement, you may say that's obvious that she would say that, but really there is a discipline and skill to improvement that is often not taught, yet I think is really vital to be able to continue to innovate and to be a part of leading the change versus being a recipient of change that someone does to us without us being involved.
That's a great point. Thank you. Thank you. Dr. Lee, there have been various attempts over the years to create healthcare delivery models that would improve healthcare outcomes and the value of healthcare, but they've come with mixed results. The Veterans Affairs has been invested in implementing whole health into the care of our veterans. A new medical school in Arkansas is pending accreditation and is anchored in whole health. And as many may know, the HSC also has embarked on a major strategic initiative focused on whole health. Can you take a few minutes to discuss why you feel whole health can be a solution to many of the current shortcomings of our current system of healthcare delivery?
Sure. Thank you for that question. A difficult one, but I'll attempt to answer that lengthy question. First of all, I want to extend a warm welcome to our distinguished guests. I feel so small being here among all the big wigs. Anyway, in terms of whole health, I'm currently the clinical director for whole health at the VA, and I often get asked the question, like, what is whole health? And in people's mind, most of the time they think of whole health as something alternative, something complementative. But in fact, the VA adopted this model of care, which is team-based approach, with the caveat that it focuses on the main pillar that the first question that goes to the patient, what matters to them, the mission, the aspiration, the purpose, what brings them joy. And then we tailor our care plan toward that. And utilizing all the available evidence-based approach, including conventional care tools that we all have been trained to provide in terms of patient care. And the VA adopted this team-based model of care way back in the 90s. So I echo the sentiment about team-based care, and certainly from my perspective, the current healthcare situation is such that a fifth of our GDP is spent on healthcare spending. That's a lot, right? 20%. And yet we're among the least healthy nation on earth compared to the other developed nation. And as a matter of fact, if you look at the Bloomberg healthiest country index, the United States ranked 35th in the world. Wow. And we spend more healthcare dollar than anybody in the world. We trump everybody else. And so something is wrong, right? We're spending that much money. We're not making people living longer. We're not making them live healthier. And so we have to look at some of the systemic changes that can perhaps focus on things that would bring positive outcome that's measurable. The VA adopted this whole health system of care based on the idea that we focus on what matters to veteran, and then we empower the veteran with tools and resources to help them manage their own care. Currently, we have no robust system-wide process that optimize or promote self-care and ultimately leading to better well-being. And so with the idea that if we can focus on the variety of integrative approach, I echo Dr. Mason about tapping into mind, body, spirit. I'm a little biased since I'm a fellow at the Andrew Weil Center for Integrative Medicine, and thinking back to the question about what I see as a physician of the future, we should embrace more integrative education, the different approaches to really take care of that patient from a holistic manner, and allowing them to take care of themselves. We become a much more of a reductionist kind of society, right? It's like, find a disease and here's the therapy for it, and that's that. But we forget about, okay, what's upstream? For example, I see uncontrolled diabetics all the time, right? I know how to prescribe insulin. I know how to give oral sulfonylurea. I know how to prescribe med. I know all those things. But if I don't take the time to find out, okay, why is that patient so uncontrolled? Well, maybe he has an ill mother at home, and he's so stressed out taking care of his mother, and he has no way to manage his stress. And he's just, you got to look at the underlying root. And this is where that integrative approach will bring positive outcomes.
Thank you, Dr. Lee. I want to follow up to Dr. Mason's first question. He shared some of his thoughts regarding the role of osteopathic medicine and what impact that can have, right? And you talked about the first question you ask a patient who comes into a whole health, right, model. is what's important to you, right? And one of our tenets in osteopathic medicine is, right, that personalized, right, approach to each patient, which kind of goes nicely with that, right? Some of the major leaders of whole health in the VA system, yourself included, are osteopathic physicians, right? We talked outside a little bit earlier about probably the one of the major landmark places where whole health is being delivered right now. Texas is in South Texas, right in San Antonio. And we just happen to have Dr. Hamai, who's an osteopathic physician who leads that. You think that's by coincidence?
Ooh, that's an interesting question because from my personal perspective, I don't think so. You know, I'm a proud EO. I'm very proud of the privilege, the opportunity to be trained as an osteopathic physician, consolidate or helped by many of my fine allopathic physician mentors, but the foundation of my physician philosophy is rooted in osteopathic philosophy, which is that holistic view of the patient. And you know, the VA went with this whole health system of care some years ago, starting with team-based approach. The VA now has if you go to a VA clinic or hospital, the primary care physician are functioning within the context of what we call a PAC, or patient-aligned care team. That team, the core team, includes a primary care physician, an RN, an LVN, and a clerk that helps with the administrative piece. So that's the core PAC team. So from that team-based approach, some years ago, the VA rolled out this whole health system of care, starting with 18 flagship sites. And San Antonio was was chosen to be among the flagship sites, and a lot of money and resources were pumped into that system transformation process, where the focus is on building the infrastructure, hiring the appropriate staff and clinician to really expand the concept of whole health, starting from what matters to the veteran, and then create a system where there's robust educational resources and tools to educate and train veterans on self-care, things that we can empower them on things that they can take care of themselves at home, while we complement that with conventional care plus integrative approaches. So one of the things in the VA, as a DO, I continue to practice my osteopathic manipulation on my primary care patient frequently. I'm also a medical acupuncturist. I provide medical acupuncture for my patients. We adopt interventions such as yoga, Tai Chi, Qigong, a lot of different integrative approaches. So, you know, the VA, some of the VA flagship, they have gone far ahead of us in terms of where we are as a system at North Texas, but we're getting there. Hopefully not in the too distant future. And I've been privileged in some previous conversation with Dr. Filipino about how we can partner with some of our local friends and partners to really promote a whole health system of change, because we need that. We need this change. The time is now, as the U.S. Surgeon General put it. The time is now to change. And I was kind of glad to know that the National Academy of Engineering and Science and Medicine just came out with a 400+ page report calling for the U.S. to adopt the whole health system of care. Wow, that's the national think tank. They advise policies for the United States healthcare system, and that's very powerful. You got the U.S. Surgeon General, the National Academy is coming out and calling for adoption of the whole health system of care. I was kind of glad to see that, to be honest.
One last question, one last follow-up, right? You know, the VA has its own ecosystem, right? You talked about one of the comments you made. The VA is dumping a lot of money into this, right? What do you see the major barriers for implementing a whole health model in a non-VA system, right? And how do we have to change medical education to prepare future graduates to do like what you just said, right? To actually build a whole health, what the current system likely not going to be able to support that type of delivery.
Thank you for that question. Great question. So, changing a system or trying to inject some changes that promote system transformation is quite difficult. People are set in their ways, in many situations, and changing culture takes time and effort. But as a starter, no matter whether it's inside a VA or outside of VA, it starts with leadership, right? You have to have realignment of your organizational goals, priorities. You have to have leadership behind that. In whatever facility or system that you're in. And through that comes support for necessary changes, resources that are available to staff, employees, students alike, and also allow resources for students and staff to experience whole health themselves. God knows about burnout in our healthcare system. You mentioned earlier about a lot of physicians are thinking about leaving practice. They lost that joy of medicine, right? Somehow along the way, we didn't go to medical school or get into some health professional school to be burned out and then have to ultimately leave your profession. Now, that's terrible. But we need to do better in terms of creating a system to support and reduce employee burnout, as well as students, staff alike. So, and the other thing is that you need to have local champions, right? So it's hard to do with just one person or two person. It takes a whole village. So if you have a local champion in a different segment of the healthcare system or facility or clinic that promote that and take charge of that, the momentum will shift eventually if you have some of that. I know in the VA, we're trying to promote that and getting staff from different services to be involved, being whole health champions, and when they help with communication, education, support, advice, be peers, a whole host of things they could do. And you might say, well, this thing requires a lot of cost and money and resources, and I recognize that, but at the same time, continuing on the current trajectory is not sustainable, right? We're spending a lot of money, and here we are talking about spending a lot of money and without a whole lot of return from that. So, and then when you start with a system change, if things along the way didn't work like it should, well, step back, reassess, but don't stop. Keep going and trying to find things that you can improve on and expand from there. Different places, different organizations will have different resources, different success level. For North Texas, we're not among the flagships, so we're in the middle of the pack, so to speak, of all the VA facility, but we're getting there. Before I came on board, there was actually not a whole lot of anything, so we've come a long way. So I hope that answered your question.
Sure. So what I'm hearing is we need our future healthcare providers to lead, right? To be comfortable with change.
Mm-hmm.
Right? And be resilient.
Correct.
Right? When things don't work out. Dr. Mason, you had your hand up. Did you have a comment?
I did. Dr. Lee really connected a few dots for me. I'm a faculty on the Andrew Wiles program for residents involved in that fellowship as well. And as I review some of the material that we teach, it oftentimes is what patients are coming to us asking for, right? And so it's becoming knowledgeable about what patients want. You started out by saying that there's been a reduced satisfaction with healthcare, and patients are reporting, reporting that they're not happy with the way the healthcare is being delivered now. So we need to teach our students and our residents that there's other things out there that may complement what we're doing, like exactly what Dr. Lee was saying, and providing those learning opportunities, not just focusing on disease and treating it with medications and surgery. So that was really nice to hear.
Thank you. Thank you. Dr. Ballum.
Yes.
One of the potential explanations as to why the current U.S. health system ranks where it does has been the fact that we do not do as much primary prevention as other nations. We still have a public health system that is fractured, and we underinvest compared to other nations in societal solutions that would address the social determinants of health. We just went through a pandemic where the medical profession finally, at least I hope, realized the important role public health plays in our healthcare system. As a physician, an expert in public health, and an assistant surgeon general, what changes do medical schools need to make to better prepare physicians to solve this crisis?
Well, first off, let me thank you for the invitation to be on this distinguished panel. It's always good to be back at TCOM. I have found memories here, and the campus has really grown, and I'm very proud of that. I see familiar faces in the audience, and I appreciate the support from my fellow PHS officer. But Dean, you are correct. The U.S. healthcare system ranks low compared to other industrialized countries, and we have poor outcome. And the COVID-19 pandemic did highlight the deficiencies in our healthcare system and our public health infrastructure. And there's been a long-standing division between the practice of clinical medicine and public health. And so addressing that issue for the future, I think it's imperative that we train future physicians to be competent not only in public health issues, but also clinical, that division should be merged together. And the way that to accomplish this goal is to consider integrating 4 years of public health principles in the medical school curriculum, starting with the first 2 years being associated with the basic science. This is a paradigm shift. This will be difficult. This will be pushback from individuals, but to incorporate the course foundation, the epidemiology courses, the biostatistic, but also public health principles into the major courses. That can be accomplished by having preceptors in all different disciplines the first 2 years, where once a week medical students will meet with a preceptor to talk about public health issues. You could have public health seminars over the first couple of years. And then at those first couple of years, you would also start community engagement, such as community health fairs, look at needs assessments in the community. The medical school would be actively involved in projects. The next years 3 and 4 are clinical rotations, and you have your ambulatory care and your hospital setting. Again, you would still have some coursework, but now you have a needs assessment. It's time for projects. Projects are to deal with advocacy and health policy. For example, here in Fort Worth, one of the zip codes have the lowest life expectancy in Texas. The question is why? What can we do about that? That could be a project at the school. The interdisciplinary training or reach out with the local health departments and the State Department. We have, the school already has the dual DOP MPH program. That could be an option for some students. And elective courses such in global health. Now, this would be a change to integrate longitudinally 4 years of public health within a system. And when you implement a new program, there's always pushback. So you would have to have administrative leadership and support in this area. Buy-in from the students, buy-in from the community and other stakeholders. You'll need resources for this. And at the same time, you would look at assessing your program and assessing your program to see what feedback you have from students regarding the clinical rotation, the feedback from students of having public health integrated throughout the 4 years, feedback from faculty, because faculty may feel uncomfortable with this because they have not been exposed, and so they would have to be educated about integrating principles of public health within their courses. And then reassess to see what improvements need to occur throughout the process. You could track graduates to see if they did take positions within the public health arena, or did they go to underserved areas or things of that nature, and take a look at the program again and improve it.
Thank you. Just a follow-up to that, right? Maybe builds upon it, maybe a little bit upstream thinking. Most medical students in the country come to medical school with a significant basic science-related background as majors, with prerequisites that seemingly make them great at basic sciences, but may not prepare them to contribute to a mindset that will deliver impactful change. Do medical schools need to begin changing what our pre-med requirements should be, or the type of students we accept? If so, how would you change them? What should our admissions process focus on?
That's a tough question. But medical schools could consider taking a mission-focused, holistic approach to evaluating the admission process. And that means looking not only at the academic aspect of it, but look at non-academic factors. There are students with diverse diverse education background that may be in the the behavioral sciences that have an interest in medical school, and academically they meet the prerequisite. Typically, we look at the basic science background and the majors for that, but taking a look at that diverse educational background for those students may have a passion for public health or the medical social determinants of health and things of that nature, which will give them a different perspective in this matter. You know, the academic requirements of basic science, equips a student to be successful in medical school. It does not necessarily equip them to be able to meet the needs of the medical needs of society. So it's important that we look at some non-academic factors along with the academic factor. We're not abandoning the basic prerequisite requirement, but you're looking at other things to get a broader perspective that may help society. The 1910 Flexible Report standardized medical training for the nation's for years. But I thought it was interesting in the report that there were two other aspects in the report that I think for 2023 and forward that we need to take a closer look at. And one was the physician obligation to society to prevent disease and promote health, which is preventive health. And the other was the collaboration between academic medicine and public health, which is the merger of public health and clinical practice, what we need. But as a nation, we're heading in that direction, it appears. The MCAT changed some of the questions to include behavioral health on their MCAT exam. There was a 434% increase in the number of dual degrees for MD and MPH. and that was from 2010 to 2018. And there's been a 20-year increase in the number of individuals who have gotten public health degrees in the undergraduate setting. So there's an interest there that I think we have the opportunity to capture by looking at these individuals who may not be the traditional student, look at those factors and balance those factors along with the academic. The academic has to be there foundationally, but also looking at other things with especially students with diverse backgrounds to bring a different perspective.
Thank you. Okay, you have a background in public health. Any thoughts?
I think I would echo everything that Dr. Bolom has shared. And I think, again, if you put this into perspective and some of the data points that have been shared, we focus on expenditures since that's the $1 trillion number. And but I think, Dean, you mentioned about the disease burden, really chronic conditions. Chronic conditions, by the science of medicine, these are preventable to begin with. So if the outcome, what we seek is health, we have to grow out of this mindset of healthcare. And I think public health, I believe COVID-19, if there is a silver lining from the pandemic, it's the larger recognition that at least primary care and public health are seeing these opportunities, that there is more benefit in integration rather than operating as two independent, mutually exclusive systems. Have we really seen widespread adoption of what that model could look like and how could we sustain? I would say still more theoretical, less in practice, but there are some emerging models out there, and I'm happy to speak more. But I think we are at a point in time where we need to continue having discussions such as this that help us reaffirm some of those, I would say, broader context that drive this movement forward. But the question is no longer about the science. The question is no longer about new knowledge. It's more about that application. And again, don't want to be redundant, but given, I think just kind of trying to be a bit more informed or coming into today's discussion, looking at the broader Fort Worth community, I just looked at the 6 zip codes that make up for a majority of the Fort Worth population. This zip code where we are in currently is about 78 years when it comes to life expectancy. You go further, like about 6 miles northeast, that drops down to 66. You go further 6 miles northeast of that, and it goes all the way up to 83. So just in a span of 11 miles, you have life expectancy going from 66 years to 83 years. These are not two different countries.
Mm-hmm. Interesting. Thank you. Thank you. Dr. Burton, you currently serve as the Chief Medical Officer of Medical City Fort Worth, part of the HCA system, the largest employer of healthcare professionals in our country. Each year, your hospital system is the recipient of new members of the healthcare workforce, particularly physicians and residents. What are the competencies you are seeing that medical education is addressing well? And where is medical education dropping the ball when it comes to delivering the type of skills you need to successfully deliver care in your system?
Thanks. I just want to give a little bit of background. Medical City Fort Worth is a 368-bed community hospital. Full service. We are not a trauma level facility, and we don't have maternal child services. I also serve at Medical City Weatherford, which is the only hospital in Parker County. We do have a maternal child mindset out there. We have delivery of babies about 60 a month. I'm a pediatrician, that's why that's important. And then we also are moving towards a level 3 trauma designation. Both locations have residents and medical students and fellows. And so it's really wonderful to be part of a GME program and to support that next generation, because we're all going to need the next generation to take care of us. And when I have interactions with those students, those residents, and those fellows, they are all kinds of smart. I mean, they are at the top of their game. It scares me because in the olden days, the attending would ask a question and then be able to step away and go pick up Harrison's or Nelson's and then find the answer and then come back the next day. But we all have to compete with what's in our pockets and what's in the noggins of these young people. And so it's just amazing what is already present in the education process of these folks that are coming to our programs. What I'm more and more aware of is kind of that third part of the triple aim. Don Berwick, another great pediatrician, talks about pop health, which we've covered tonight, per capita cost, but experience of care. Yeah. And the care experience is really, I think, the brand that our hospitals are needing to look towards, because the care experience that our students, residents, and fellows are needing to deliver is a lot higher expectation from our patients and our staff than I think we've ever experienced before in healthcare. There is a real mindset of the consumer, whether it be Google reports, which we look at those monthly to see how HCA and Baylor and JPS and THR are doing. We all want to get that 5-star, but the tactics to make sure that you're delivering that are incredibly varied. And so I really think that we are working on the care experience from our student standpoint and teaching them if that is something that we could move to the left in their formative training. I think that would be really remarkable. And I think that life of service, the Admiral brought up about how we are looking at the non-traditional students and what does the life of experience of service look like for them? Not just that they did a weekend or a week or even a month, but looking at those soft skills that a life of service or an experience of service delivers. I think that that's an area that will help us because we really are working on retaining staff. So as our residents and fellows and students lead on the floors, they are working on retention. Because if they're helping to build that team of the nurse, the support services, they are also working on retention. Because if they're building a team where people want to show up to work and to fulfill their why, it gives them that opportunity to lead in a more precious way. I think the definition of leading is getting people to do things that they would not otherwise do on their own. And so we have many novice individuals on staff who don't even know what that looks like. But all it takes is just the gentle word or a kindness or a compassion on the floor, getting to know each other as a team and looking to see what is brought to the fight every day up on the units, gives us an opportunity to really build a team that people want to come back to work with the next day.
Thank you. Thank you. President McGaffigan. In 1999, the Institute of Medicine released a landmark report, To Err is Human, Building a Safer Health System. Where does the nation sit right now in preventing medical errors since that report came out nearly 25 years ago?
Right. The 25th anniversary is frightening, and my answer may frighten you a little bit as well too. What caught the attention of the public, and quite frankly of healthcare, who really didn't have a sense of how safe care was or was not, was that 98,000 lives per year lost to preventable medical error. What was less appreciated in the report, though, were some of the recommendations. There was federal funding recommendations, and many of those were invested in. But it also really illuminated the fact that safety had to be something that we focused on, that we understood better, and that we invested in, and that the discipline of safety was something that was really, really unique. Healthcare, a high-risk industry, and the solutions to be able to proactively prevent harm in high-risk industries are really well understood. But in healthcare, what we were finding is we weren't really appreciating that safety was the system property. In fact, our kind of go-to approach when something went wrong was to blame and shame people. And Lucian Leap, who is the founder of our patient safety think tank, has always said one of the greatest detriments that we've had in advancing safety is we continue to punish well-intentioned people for making mistakes, when the reality is the systems issues and the systems that they're working in are not well-designed or intentionally designed to be able to provide those fail-safe experiences for patients and for staff. So have we seen improvements since then? I would say yes, in many pockets we have. We have not seen uniformly applied principles that address healthcare as a complex system, as a socio-technical system, where there are system solutions that need to be proactively put in place. So I would say overall, we're probably still talking about some of the same stuff that we were talking about 25 years ago. And for some of us who've worked in safety, and many of you in the room, it's probably just one of those deja vu moments where, you know, every few years we see more and more reports that come out and tell us the same thing over and over again. Just another report that came out in January of this year from where I'm from, up in Massachusetts. 1 in every 4 patients are experiencing adverse events in hospitals. In many cases, more than one adverse event during their stay. And the concurrent cost is certainly there, but more importantly, the impact on patients. And by the way, the care teams that are caring for patients who are also harmed as a result of those continued failures to really proactively address safety. I think we know what we need to do, and we haven't got there yet.
What do you think some of the barriers are?
A few. So I would say some of the barriers in general for the how we've been approaching safety is what we call the whack-a-mole approach in our common parlance. If we track our reports over time for healthcare-acquired conditions such as infections and we see them go up, we suddenly, just ring the bell for another performance improvement project that is focused in on fixing people, mostly through get more education and follow the protocols. But what we haven't necessarily done is take a look at the systems that they're working in to be able to identify what some of those risk and system factors are that can really, really make an important difference. I would also say that we spend a lot of time thinking about and conflating quality and process improvement with safety. And we know that process improvement is integral to safety, but if it's our only strategy, we will continue to have these conversations 25 years from now. Because again, we haven't really necessarily taken the science of safety and applied the practices that we know that are very, very well established, particularly from other high-risk industries. And then the third, I think, barrier overall is that if we understand, we talked about going upstream, the need to go upstream to be much more prevention-focused when it comes to health, but also to be able, again, to kind of architect systems that are safe. But at the same time, we are forgetting some of the ecosystem requirements for safety. And I happen to co-chair the National Steering Committee for Patient Safety. We developed the first national action plan for patient safety in this country 2 years ago. And we focused in on foundational areas that are absolutely essential, no matter what the safety challenge is. The first is culture, leadership, and governance. The second is meaningful and deep patient and family engagement in their own care, but also in serving as critical team members to improve the systems in which care is given. Workforce safety, well-being, and joy, which we've talked about as well, and that sense of really feeling that what we bring to work every day is valued. And then the fourth area is really focused in on learning health systems. Lots of times when we have errors right now, for example, we do root cause analyses, and we dispatch the team to do RCAs, but we don't necessarily have any deep learning. And we just finished a whole innovation wave on this to ask about 40 people, experts from around the world, what happens in your organization when you do RCAs? What happens to event learning? And the event learning is often stagnated. It goes into the hopper for whatever regulatory obligation needs to be addressed. but at the same time, learning within and external to healthcare delivery organizations has been one of the very limiting factors, and that's why we focused in on learning systems as the fourth key priority. So I think those were some of the barriers.
Do you believe medical education is delivering on that? Patient safety education? Are we sufficiently preparing our students in doing this?
And by the way, my comments would apply, I'm a nurse by background, so my comments would apply to nursing education as much as they would to medical education. I think what we've seen is that it's highly variable. We educate and have resources that are used by academic settings around the world. And in some cases, we see that safety is a module that you do online and you're good. You've done safety and you're now safe. And we all know, and this organization more than any organization knows that it is absolutely not sufficient for safety. I would say that we're seeing a whole lot more of health system science and an understanding of systems and professionalism, and we're also seeing more safety that's deeply integrated into the academic program, but again, very unevenly. Don Berwick, who you mentioned earlier, is on our Lucian Leap Institute. He's been there since its founding. We had a retreat back a few months ago, and he said, and this happens to be a medical school up in Massachusetts. I won't name them, but you could guess a few names and you'd probably be right. He said a recent graduate came to him and said, I don't remember where we had safety in my medical education. I can't palpate it. I don't know where it was. It didn't stand out to me in any way. On the flip side, there's probably no organization in the world that is doing what is happening here at TCOM, at HSC. The way that safety is integrated throughout all 4 years of the program is so well designed and intentionally designed to be able to build upon the competencies of people over time. And that has really been driven from the top down, from the president, the chancellor, the provost, the dean, the faculty that are in this room as well. And I think the exemplar of this program that I'm just so incredibly impressed about is 27 faculty are certified in patient safety. And every single student in their third year is going through a 2-week intensive course around safety that is based on the certified professional and patient safety competencies. And nearly every student is graduating from this program. Some of you probably know this well, and some of you may not, wearing the certified professional and patient safety credential. They have a complete 4-year program, and the vast majority of students have demonstrable competencies that even some of those who are completing their residencies have not yet established. So, just an incredible, incredible difference. So do I see schools that are doing, or programs that are doing this regularly? Absolutely not. We're starting to see, and I want to thank the faculty of this program, the dean and Drs. Linas and Lieto, who are meeting with other programs regularly to be able to help share why this matters. And the starting point is leadership, and leadership saying safety isn't something you will do every single day, no matter what your specialty is, no matter where you work, no matter who you're caring for. And it's not a priority. If we say safety is a priority, then that means we can deprioritize it when something comes around. And the difference here is that this organization, this wonderful institution, is that safety is our purpose. It is something that's enduring, it's a core value, and we are demonstrating and walking the talk on embedding it as a core value in all of our graduates. So my compliments to the incredible work that's been done down here. Talked about changing programs, and this is a whole switch of the program that took place, I think, over about a 3-year period to be able to put this into play with 760 students that have now gone through the program. So,
Yeah,
wish it was everywhere.
Yeah, that's what I was going to say. I've been fortunate to be invited to come to your conferences and talk about what we did and share our success to get more people to buy into this buy into this change in medical education. Are there any early successes that you're seeing out there that are saying, we want to do what TCOM's doing? And who are they?
We're seeing some. Kaiser's just starting. They have a fairly new medical school, and they're starting an elective course. And we've got other programs, and some are graduate programs in quality and safety and in nursing that are looking at integrating the programs as well too. I think what's so incredibly orchestrated here is the building blocks from day one all the way through till graduation. And again, not just saying safety is this module that you're going to do. Safety is something we're going to live and walk the talk on. If I could wave a wand, this would be the program that I think would be a difference maker. And it's what Don Berwick led our Lucian Leap report on the need to reform medical education and had this vision. It was the very first thing the Institute did when they were founded in 2009, was focus in on reforming medical education to be able to create people who could practice safely and who could design systems that were safe as part of their daily work.
Well, we certainly value your partnership, and again,
Thank you.
you had to give us permission to do this, and we thank you for giving us permission to do this. We'll move forward. So Dr. Burton, we just heard from President McGaffigan regarding the continued issues related to patient safety as a major issue within our healthcare system, and it's a particular area that HSC and TCOM places emphasis on. Can you tell us about the importance of patient safety and the emphasis that your hospital puts on this?
Could I ask for some group participation?
Sure.
So I'd like to ask you a question, and I would say that since we've been together an hour that we've developed a little bit of a relationship. But I'm curious, if you yourself have been harmed in the medical healthcare line of work or been a patient yourself, do you mind standing up? And then the next question that I would ask, thank you very much for standing, so keep standing. If someone you love, you know well, or someone you've cared with has been affected by harm in the healthcare setting, would you stand up? That's why we're here.
Yeah.
It affects all of us. And please have a seat, and thank you so much for your vulnerability. We can't stop this desire in our hearts as caregivers to care and not harm. We just can't. We have to do something about that. That's how we're made. And so I appreciate the fact that you are here, curious about what is going on in our community. And I would share with you HCA, 182 facilities across the US and the UK, very dominant in Texas as well as Florida, has done really good work to decrease significant healthcare acquired conditions within the facility. Reductions in central line infections and urinary tract infections, things that we found out during COVID, such as a central line, making sure that that area is clean, dry, intact. Little basic tactics. A Foley, make sure that it is attached to the leg. It has no loops. It's down, not on the floor. The bag is close to the floor, but there's a dependent drainage. Just little tactics that we've been able to make sure have happened in our facilities has decreased those two healthcare acquired infections by upwards of 10 to 20% over the COVID period. And those are represented in metrics that you can see front-facing. You can look at the CMS star ratings. Those are areas I think are very important because that is public-facing data, and it's data that's extracted. It's not that there's someone behind the curtain, writing into the metric. The other metric I think is really important to look at is Leapfrog. Leapfrog does a really good job of taking objective measurements and looking at that across a community. And TJC has also their quality check. Those are areas that you can, as a consumer, go out and do the shopping. Google has kind of like your Yelp kind of experience for patient care, I think it's important for you to look there. Everybody's looking. And so if you're going to be a well-informed, if we're going to be a well-informed consumer, we have to gather all the important data because it's our lives, it's our families' lives, and we want them to have the best care possible. And so I think that HCA is one of the leaders in this community. THR does a very, very good job of instituting good methods for training their staff, understanding the challenges of healthcare and acting upon them. Baylor Scott and White, they had, I don't remember the number, but they had the overwhelming number of 5-star CMS rated facilities in the Metroplex. So I think in Tarrant County are really very blessed to have organizations such as JPS and THR, which are level 1 traumas. If we are in an accident, we're in a best place to get that golden hour taken care of in a timely manner. If you're a kid, you have Cook Children's. What a great space. So Tarrant County is very, very rich. Not all counties can experience that. And just as was discussed, 76104, very challenging zip code, which is the near south side. So we have a long way to go. It affects all of us, and it's really important for us to lean into these conversations so that we're good consumers, but we're also good providers of healthcare.
Thank you. Now, for those of us with the CPPS credential, right, the outcomes we see in patient safety often are related to leadership at a hospital, right? Your hospital, Medical City Fort Worth, received an A in the latest hospital grades for patient safety last spring. But yet we've had hospitals in the DFW area receive C's, D's, and F's. Probably most of our listeners here probably don't know the hospital that they go to and what their ranking is. But we use ratings in every other part of our life, right? Why do you feel some hospitals excel at this, and yet some just don't make the grade? What can be done to assure that all hospitals excel in this area?
Well, first of all, I would encourage each one of us. I think everybody's got a favorite brand, right? I'm a Coke guy, you might be a Pepsi gal, right? Some people might be a Baylor person or a JPS. I encourage you to get involved. Every one of our hospitals has a consumer or a group that looks for community involvement. I think that's the first place to go. You can look on their bios and you can find out who their patient safety director is or their quality director or their chief medical officer and say, I really like your brand and you're in my community. I would really like to be part of your consumer group, because we're always looking for people who have been involved with our care to give us feedback. I think that's a first place to go. And I do think that our facilities ask for that, but they don't always get the right people. So if you believe you're the right person to serve on one of those community action groups, go for that. I do think that we are incentivized monetarily for different matters. It's been very challenging for our healthcare systems who don't have enough nurses, don't have enough CT techs, don't have enough EVS or food nutrition services. We are challenged with finding the right people to come into healthcare and to serve on their why. And so I think that that's one of the challenges coming into the post-COVID world, is trying to figure out where we're going to allocate resources to ensure high-quality, safe patient care. And I think that we're on the other side of that tumult, but we still have a ways to go. When we cannot have staff that stay with us to build a culture that we have not been able to bring into a family of healthcare, it makes it challenging to ensure that they're the right people to deliver the healthcare. And all of us have been challenged with that in the post-COVID world. And so the more that we do to work on retention and making sure that people are coming into healthcare for the right reason, then I think that we'll be more successful. And we are in a resource-constrained environment right now.
Thank you. Next question is for Ankit. Okay. You are the current executive director for the Texas Health Institute. Your mission is to improve health of Texans and their communities. Part of your work is helping build capacity, competency, and performance of the current and future healthcare workforce through partnerships. One of the links on your website mentions the term innovative leaders, being at the core of a dynamic healthcare and public health ecosystem. How important is it that concepts and the importance of innovation and entrepreneurship are introduced in medical education in order to create professional identities of medical curiosity, systems thinking, and problem solving?
There is a lot to unpack, and I think we should have this as an ongoing exercise to truly get to the heart of the conversation. But for the sake of brevity, if the question is asked like how important it is, if I say today, maybe a bit more important than it was yesterday, but if I look into tomorrow, it's a necessity to survive. And I'll try to unpack just in reflection of the discussion that we have had today to further justify that construct. So we talked about spending, and that spending is not going down anytime soon. In fact, just a couple of months ago, Health Affairs, and there is a national publication that it's projected to be upwards of 20% by 2034. So it's not going down. But let's try to unpack what makes up that big number. And when you try to peek in, this is all of information that's available in the public domain. And I encourage to speak to some of the remarks that Brett made, that it's out there in the public domain. We just need to be able to find it. But for the purposes of this discussion, that 4 trillion and upwards number, 90% of that is towards prescription, so pharma, and hospital-based care. However, when you take a step back and look at utilization, 50% of utilization of healthcare services is delivered by primary care, which documented does have an impact on 90% of the health outcomes. So if there is anything positive that keeps us as 35th in the global index, 90% of that comes from primary care. But when you look at actual spending, of that remaining 10 or 15% that we have, primary care across the board throughout the country accounts for about 7% average. And this has been the historic story. So what we are trying to solve here is how are we going to make healthcare a bit more effective? The reality is it's a more of an economic problem and less of a healthcare or science of medicine or science of healthcare as a problem. So that's part of the construct. Again, given that this is not changing, I would say it's more of a necessity tomorrow and some level of urgency in between now and then. The second construct, we also are talking about the need to take a prevention-first approach. But I think Dr. Basin just set the tone that we are living in a fee-for-service, a sick care system. That's how at least physicians are paid for. The clinical care team is paid for. Over the years, positively, while the recognition has been to move towards recognizing health equity or addressing the community conditions, social conditions we refer to as social determinants of health, you're expecting the same person now to do more. You add to that the delivery or pursuit of whole health. By background, I'm a dentist, and it is that journey that brought me into public health in the first place to begin with. And we talk about connecting the mind to the body, body to the mouth. And that's whole health, right? The reality is you're still expecting the same person without really changing the larger environment for them. What has boiled down to, and when we think about this larger shift or what we hear is value-based payment transformation efforts that is moving from this fee-for-service model to like a per person, per patient, per month model, which is like the category 4 of a value-based payment model. Really the genesis or the expectations are out of that physician, out of that clinical care team, that one of the derivative as an outcome is burnout. So to survive, you will have to start thinking about the non-clinical decisions you have to make, finding those process efficiencies in your clinical workflow, finding the ways to make sure that every member in the team is optimally used for the value that they bring. Because at the end of the day, that's going to be the math that's going to help you determine what is the true incentive. More than the incentive, what is the true cost for delivering that outcomes we are expecting out of that same team. for reasons that probably don't really belong to them. An outcome of that why even that needs to be happening is, as of today, the two largest group or sources of employment for physicians in Texas are health systems and payers. So while we are talking about primary care and this increasing cost curve, we are having the steepest decline, not just in Texas, but Texas, given our geography, we are going to experience this more than any other state across the country, because we already had about 40 counties of the 254 counties in Texas that have no primary care physician. And that's going to go up to 80, because any rural clinics or small towns that had primary care, you're either having those primary care physicians that are retiring out of the workforce or have already decided on early retirement as a part of the pandemic. The second, that are more close to cities and towns such as Fort Worth, they are being brought out by this equity groups or backed organizations, because they have the mechanism, they have the infrastructure. Amazon talks about, Chase, CVS talks about entering into the space because they have the infrastructure, the mechanisms to be able to truly get the full value when I talk about VBP or an incentive-based, value-based incentive payment model, which the physicians that are operating, leading those clinics were not trained for 40 years ago, 50 years ago when they went to medical school to get their training. So at no option, you basically look at an exit strategy. And it's too good or it's too high a number to be able to speak into. So if you really want to look at health and ensuring that every community in Texas realistically has a primary care physician, a resource to receive health care, the clinician will have to do something different to survive on an even keel. And the last part, and I think, Brett, you spoke to it, is experience, that we have an aging population. Their needs are very unique. Their expectations from healthcare are very unique. Like, so what I am going to look for on your Google review is going to be very different than her. And what we are seeing objectively is the younger generation, which is also fast growing, is on the polar opposite end of it. That what we have when we think about PCMH, patient-centered medical home, that's part of the primary care work or foundation of the primary care work that the Institute has done or been engaged in over the last 15 years. Fundamental to that is patient-provider relationship, that trust, the ability to be proactive. The reality is the younger generation kind of prioritize convenience over patient-provider relationship and get engagement. And so when you want to meet their experience, you want to be responsive to that. We are in a very consumer-driven world these days, driven by social media that is around instant gratification. So they don't want the whole health outcome. They just want to be pain-free at that very moment. And that's what's going to bring them into healthcare, or at least that's what the report, the data suggests. So how do you basically be relevant into that you are capturing the patient profile that you are probably going to be targeting, or that's part of the community you seek to serve, and designing and continuing to evolve, because these are the expectations today. Sure enough, 10 years from now, it's going to be a different set of expectations, so you'll need to stay relevant. Otherwise, you are out of business. So I think entrepreneurship innovation is more of a necessity. However, it's not about finding new ways of doing things. It's just the ability. That's when I think you asked earlier, Dean, that, do we redefine? I wouldn't say it's redefine. It's this reimagination, re-envisioning, and keeping that as an ongoing exercise. So it's kind of like rewiring the way we have traditionally thought and kind of continuing to keep a check on the evolution and keeping pace with that.
Great, thank you. Our last subject that I want to talk about tonight is the importance of advocacy.
Absolutely.
Right? Advocacy for our patients and health policy. All right, so then I have a question I'll throw out to Dr. Mason, Dr. Ballum, and you, Ankit, right? But anybody welcome to answer this, right? What changes do you think medical schools can make to emphasize the importance of advocacy and health policy innovations among all future providers versus simply relying on a few who may become involved in such activities during their time in medical school? So in essence, should the competency to write a health policy brief raise to the same importance as writing a SOAP note? Who wants to start with that one?
I'm happy to kind of just speak to, just given that's where we have been spending most of our time to kind of move the needle on systemic things. I think first and foremost, we live in an, if I have to think about the greatest threat right now is this cost equation, access equation is a chronic challenge. So it will need really a management prevention solution. But I think if I have to look at it from an acuity of the condition, it's misinformation. And it's misinformation, not just patients coming into the clinical office, but these patients and some, I would say, special interest group advocating, not based on science, to our elected officials. And the pace at which that information is being generated, it's being communicated, no matter whether it's 30,000 physicians a year or 300,000 physicians a year, we can't keep up. But we need each one of those 30,000 to be able to be empowered, to be able to be educated and made aware of every resource right from the local level. Because again, with the pandemic, it wasn't really the state and national action that was causing a lot of frustration or confusion, because if you ask the community, it was really what they were hearing from their local news outlets, the CBOs, and the groups or the religious church, whether it's a churches or another faith-based place that they were going to. And it's kind of getting involved over there. That's where the county judge is going to get a lot of insights from or perspectives from. So you have to counter that at that source of origin so that it doesn't reach the offices that they probably may have the best interest, but they are going to see some of the special interest group more by their frequency than having the true physician come in and actually give them a piece of science. They will act on science, but they just don't have that opportunity. So I think it's not just kind of being engaged in the world of organized medicine, which we see a lot or most commonly referred to. I think that's an important venue because that's where you are able to bring in a collective voice, by, if I may say, a level of influence. But if that seems to be unrealistic based on your place of employment, being in a dental or medical school, or just for the community you are in, think about those opportunities that is talking to your county judge. And if you as a physician can be that primary source that the judge has a question and is able to pick up the phone and ask you, I think you have done your part.
Yeah.
Thank you. Any?
Yes, I agree with that. I think physicians are in a unique position to be advocates for their patients. You know, they know their healthcare needs. They know what social factors are influencing their health, and they know their financial burdens. They have a role in society already which could, with their professionalism and expertise, could help make changes in systemic issues that we have in our society. And by that role, they also are positioned so that they can bridge a gap between the community and the policymakers. So it also goes back to integrating advocacy and writing health briefs into the public health curriculum and the four-year medical school experience. So if they are advocates, let's say they have a public health seminar and they wanted to address what we've already talked about, the life expectancy in 76104, at that point the question is, why is that? You know, what advocacy can I do for those patients? They look at the needs assessment and what can I do in that, and look at that zip code to make a change. And then as they go through the third and fourth year, then it may be at that point that they say, well, we can write a policy brief. You know, they go to workshops, training, and things of that nature, and may make a systemic change for possibly that neighborhood. I think all physicians should be trained in this area, because more in all disciplines, because as it was stated, there's so much misinformation out there. And even though physicians may speak among themselves, but if they have the tools and the skills and have the training, they feel more comfortable speaking out in regards to that misinformation. And as more trained, then you have a louder voice. If you leave it to a subset of physicians who are always out there, they tend to be ignored and ridiculed and harassed. But if you have a large group, that will make a larger impact on the issue. The SOAP note is more of a care plan for the individual patient. But when you look at a health policy brief, it's a care plan for the community. Right. So having both of those in a physician toolbox would be beneficial for the community.
Thank you. Anyone else? Thank you, Ari.
Yeah, I think it's important to teach these concepts because most medical students, residents, and most physicians don't know how we got into the situation that we're currently in. And therefore, they don't know how to dig themselves out. And I think one way to combat moral injury is by having autonomy and having knowledge and power to make a change. So I think if we empower all of them, as was just stated, we can all go and find problems and then innovate solutions.
I just want to echo what's been said already. And, you know, as physicians, we are our patients' strongest advocate, right? If you can't advocate your patient, then what are we doing? And so and when you talk about patient advocacy, you're talking about looking at different dimensions of health. And from a micro perspective, meaning the individual patient, and then from a macro perspective, system and social determinants and whatnot. And interestingly, the University of Wisconsin Health Population Institute has a county health ranking model. It's a model that takes all the data from all the counties around the United States, and they put it in this formula and try and determine, you know, what's affecting health outcomes. And it turns out that only 20% of factors contributing to health outcomes are influenced by what we do in an office, what we do as physicians and clinicians. The other 80% are outside of that wall. And so if we want to be the best patient advocate, you have to think beyond that problem, think beyond the issue at hand, but look at the systemic issue and try to be involved and remind ourselves that if we don't do it, who's going to do it? And I echo the fact that, team up with others. You can't be by yourself. They're your teammates, and add as more people as possible in trying to exact that policy change. And I wish I had more education about writing up policies and whatnot. And in my role as clinical director, I mean, I'm having to write policy, but I have to go back and look at all the different policy and kind of look at, okay, how do they write those things, Look at the language.
But we taught you how to write a good SOAP note, right?
Yeah, exactly. I mean, I was very good at writing SOAP note and doing my PQRST and all that stuff, but I wish I had some training on looking at health brief, health policy, thinking beyond that and to be true patient advocates.
Thank you.
Dean, just to piggyback on that, something that I think the schools could do practically is, probably just resources to talk about health in all policies approach. Because if you want to deliver health, it's not about advocating for healthcare policies, but just like every time the community releases a plan to develop a park or for a new intervention, there is a health implication there. Mm-hmm. And if as a physician you can go in and provide that, what are the health considerations, we may be producing health in this community in venues that we have traditionally not thought about. And that's your job as a physician. Thank you.
Well, our time is up, so I want to thank our panelists for, again, sharing your wisdom, your expertise with us and telling us how to move that needle forward and how we address healthcare in our country. So let's give our panelists a round of applause. They did great. Again. And once again, thank you for attending. Again, those online who are watching this, thank you for watching. And again, let's do better in healthcare. Thank you.
Thank you.
Thank you.
Have a good night.